Hello, everyone. Those of you that have already joined, we're just going to give about 25 to 35 seconds of pause here to let other people join. I'll time it. We could put some background music on, Jeanette, if you want to. Something nice like the Beatles. Help pass the time. How's everyone doing today? Ready? Ready to provide some insights, some thoughts? Great. Give it just a few more seconds here. Let me make sure I got this straight here. All right. Okay. Well, hello, everyone. Thank you for joining today. I am Bridger Meekum, VP of Marketing at CareXM. I will be moderating today's event hosted by Home Healthcare News. Our thought panel topic is strategic modeling to lower costs and improve outcomes in home health and hospice. We'll feature strategic modeling, learn how some new approaches and models can help your home health and hospice organization effectively plan, adapt, and optimize your operations. How to get ahead of the curve as well with the evolving landscape of staffing challenges, pinch margins, adapting to value-based care. We'll cover some innovative strategies to get out ahead and improve quality of care. And then also, last but not least, we'll have our expert panel. We'll have Jeanette Dove from Bristol, Nicole Snodgrass from Providence, and Christine Rodriguez from CareXM. And I'll give more of a formal bio and background of each one of them here shortly. Today's topic is really focused on, the pulling forces that we're all dealing with in home health and hospice. As we adapt to value-based care, we're dealing with trying to, from an owner executive model, overseeing a business and trying to show care in our business, in our P&L and lowering costs. We have a pulling force of meeting patient demand, both in sheer volume and expectation of timeliness of care. And then especially taking care of our clinicians so they can take better care of our patients, and those three aspects, those three ideals are typically kind of a tug of war and a pulling force. So how do we align all three to row the same boat and accomplish what we're all looking for here? So that's really the genesis and main theme here that we'll talk through. I'll introduce each one of our speakers now. First, we have Nicole Snodgrass, Director of Operations, Hospice and Palliative Care from Providence. After receiving her master's in arts and bioethics in 2009, Nicole started with Providence as a program coordinator, where she developed, measured, and successfully implemented palliative care programs. Since then, she has quickly risen within Providence to the Director of Operations for Hospice and Palliative Care. During this time, she has helped drive metric-focused initiatives in training, change facilitation, mentoring and coaching, program launches, and overall operations. Outside of her impressive results and leadership within Providence, Nicole enjoys time with her husband and 2 children and finding any spare time she can get to get a break and relax with a book. We also have Jeanette Dove. Jeanette is an Executive Vice President and Chief Quality Officer for Bristol Hospice. She sits now on the board as she retired and started her own consulting business called Engage as well. Jeanette began her nursing career as a critical care nurse and has worked in clinical management positions within the hospice community for the past 15 to 35 years, Jeanette? Not to date yet. Yeah, 35 years. She has presented educational offerings on a variety of topics, including performance improvement, quality measurement, and clinical outcomes. I believe you admitted the first patient at Bristol, correct? Okay. And helped grow it to a 5,000 census overall. Jeanette is an RN and holds a master's degree in human sciences from Our Lady of the Lake University. Thank you both for joining today. And last and definitely not least, we have Christine Rodriguez. She is one of our nurses here at CareXM. She has and leads the team here. Christine has spent many years working as home health, in home health, private home care, and as a hospice administrator, building billable hours, increasing census by 50% or more, recruiting and retaining high-quality staff, and piloting and training staff to new EMRs. She's been able to also keep her clinical skills sharp by providing hands-on care, training new staff on IV placement, line infusion and care, comprehensive wound care, and wound vac therapy. Her work in communities of El Paso, Augusta have opened her eyes to the racial and ethnic disparities that exist in the US today. She is very passionate about helping families and all families navigate and understand the world of hospice, home health, and beyond. Thank you, Christine, for joining us today. So with that, we'll start with questions. Please feel free, audience, those that are live here, please ask questions as we go along. We'll have time at the end to address any questions. Now is a great time to pick these wonderful folks' brains. These are leaders and just amazing experts in the space. So do yourself a favor, make sure you ask questions as we go along here. So as I discussed, we have the pulling forces, that what we're dealing with in home health hospice. We all need to challenge our government leaders and CMS, for more support. And until we get that, let's keep making sure we are squeaky wheels that get the grease. But in the meantime, we do have these challenges that we're all well aware of, with staffing challenges, especially squeezed margins with inflation, and the adaptation to value-based care. So with the current environment that I just outlined, what do you feel is the most important action providers can take that's maybe a low-hanging fruit to combat some of these challenges?
Well, Bridger, I'll kind of start out here. And some of the people that are joining us have heard that I always operate by saying that helps me in this time, especially during the challenges. And it's not the strongest who wins in life, but it's the most nimble, flexible, and adaptive one who wins in life. And I think that's what's really led us through this time of the pandemic, post-pandemic, and then all the items that you just discussed, Bridger, about payment models, value-based care, staffing. I mean, they're huge problems and huge mountains that we all have to climb every day. But I kind of operate off of that as I go forward. And I found with the biggest challenges that you just mentioned, for me, it has really helped me to be very nimble and flexible and empower our team and trust our teams. I think that's the biggest thing as we've gone through the pandemic and post-pandemic, is learning to hear and trust our teams, that they can really give us valuable input, not only for clinical expertise and clinical things at the bedside, but they can see into greater areas of the organization like operations, HR, and finance. So I think just trusting and empowering my staff has been one of the things that has really helped.
I think to add to that, fostering collaboration is essential internally and externally. So establishing partners and collaborating with other healthcare organizations and community resources, really trying to create a network of support that addresses the same issues that we're all facing: staffing, reducing costs, improving outcomes. We saw a lot of this during COVID. I'm based out of Los Angeles, and it's a very competitive market, home health and hospice. And usually we see kind of jockeying for position. And really during COVID, it required all of us to kind of come together and look at best practices and say, where can we leverage each other's expertise and different vendors that everyone is using in order to better care for the patient population during that time. And we've seen that continue even after the pandemic has slowed down a bit. I think that collaboration piece, listening to what our customers want, and meeting what our individual customers are asking for is really essential as well. The other two things I think are really important is investing in workforce development. So really making sure that you have comprehensive training programs, that your new hire orientation and onboarding experience is really great, because we really want to not only attract, but retain talented professionals, and really ensuring that they're having an enriched experience really will enhance their quality of care that they're able to provide. The one other item is really embracing technology. So leveraging innovation, automating as much as you can, and really helping kind of alleviate that documentation burden that we see. I know we want everything to be in the record, but really what is essential and what's nice to have. So, leveraging and embracing technology so that it's efficient and effective and not creating a greater burden for our staff.
I think given the environment of the pandemic and what we've seen happen to nurse staffing and people leaving the workforce because of, different factors, being overworked or, in hospitals, being abused in hospitals, the shootings, all these things that have happened, nurses are leaving the workforce or seeking roles that do not include direct patient care, be it, whether it's triage like we do or actually in the home. And so we have to be, we do have to be flexible with our staffing, but we have to do it in a way that doesn't overburden the staff that we have. And so, when I looked at, this has happened, when I was a home health and hospice administrator, but we looked at our budget for training and realized the amount of money we spend on training people who don't get retained could pay the wages of somebody for like almost a year at some point. Hospice has a high rate of turnover. It's an incredibly stressful calling. It's not a job, it's a calling. And if you're not called to do it and you're just there, these people don't stay, especially when they don't feel supported and educated. And so just like Nicole said, that ongoing education and really investing in keeping those people there so that your patient care, your staffing is not the thing that is your biggest crisis. You can focus on some other issues. And also with, things like supplies and, DME and things like that, those partnerships that everyone has, created with different organizations, where we had we had several different partnerships and people were constantly wanting to collaborate. We had to review everyone's, formularies and different odds and ends. And we did that in a meeting. We did that as a group every other week. So in IDT, we were looking at equipment and who was doing what and what people really needed. And we found that a lot of our nurses with the biggest hearts wanted the best for their patients were ordering tons and tons of equipment, thinking it was needed. And then I'd go in and, cover a visit and find all of this stuff piled in the corner. So we started keeping our DME as part of our IDT conversation every single time for every single patient, because we realized we were just losing money like crazy with things like that for things that they didn't need. And so really having a sharp focus on what does this patient and this family actually need, and not what the nurse thinks they need, but what they feel that they need to be successful, and then constantly reassessing that. And that led to us rearranging staffing, rearranging visits, and coming up with, and of course the DME and supplies, coming up with a plan to, keep some of our money in our pockets so that we could then invest it in our staff. So just being really judicious with those pieces as nurses, not just as administrators, but as actual nurses out in the field, I think is a super big piece of the puzzle.
I love that approach, Nicole and Christine, because I really would agree with you that it brought hospice and home care to a new level. Even though it was an extremely challenging time, one that we felt every day we weren't making any progress forward. It's like we were kind of behind the ball every time you got an update from, CDC about COVID and what you have to do tomorrow. But it really brought us to a new level within home care and hospice to do exactly what you guys have been talking about, and continuing to apply it now. I think we can do greater things like really invest more money in our staff, really look at how we retain them and how we support them. And we've always looked at how do we make our patients and families feel. I think now we've really looked inward and said, how do we make our employees and our staff and our clinicians feel within our organizations? And that's what retains them.
Love that. No, that's great. So in light of that, I'll move on to the next question. What are some models that you've seen be most effective for improving outcomes? It could be clinician or patient-based or both.
I can just talk about what I learned in role modeling and modeling for others within our organization and without, was just really having a really robust and purposeful QAPI program that not only lived at the location level, we were a multi-location company, but it lived within each one of our staff members. So really educating them about the things we just talked about, involving them in the QAPI initiatives, helping them learn the methodology, the hows, the whys, the whens, and really discussing those within IDT really empowered them to be part of the answer instead of seeing QAPI as a burden. It became a living, breathing part of our organization.
And I think that's super important given the staffing issues that are existing in healthcare too, because people are you're taking on so many roles and so many patients. But when we had our new nurses that would start in hospice or even home health too, we all know if you've worked in hospice for any period of time, you know that we say all the time, you are not a proficient, like really competent hospice nurse for at least a year, sometimes even more. You just can't learn everything and things just happen as you work. And so they're constantly learning on the job. And then, if we're not putting the ownership of the QAPI programs on them, they don't learn it. It's just a thing that exists around them. And when it just exists around them, they don't internalize it and they don't practice from it. So when we were I was the part of a branch that was just starting a multi-location, and we kind of split off into we were on a state border. We had to rebuild a QAPI program for this new office, and we had an opportunity to do it how we wanted to. And so trying to bring people in at a point in time where staffing was lean and they were feeling crunched, they couldn't learn it. They didn't want to know it. They wanted to just go out and take care of their people. But when staffing was more robust and there was room to breathe, bringing everybody in and really making them part of the process, then they started practicing from that place. And a lot of our quality measures improved, a lot of things, our star ratings improved, like a lot of things improved just by having them own it. But so many of them just felt like they couldn't in those very early days. So we really picked and chose how we put that out to them after they had been with us for a considerable amount of time, because your primary focus is the patient when you're a nurse. And we hear that all the time as leaders, like, I'm just worried about my patient. Like, we know, but part of worrying about your patient means worrying about business and keeping us all in business, which means we have these other things that are still partly your responsibility too. That ownership is huge.
Yeah, I think creating a culture of safety and really engaging our staff to feel comfortable that they can speak up for safety and that they can speak up and that we're listening to them and we're hearing them and we're implementing and changing models of care based on their feedback and their experience in doing the work. I think as many variables as you can control in clinical practice, like standard onboarding, ongoing education geared towards gaps in skills and proficiency, that feedback should come from the staff and where they feel that they have opportunities and where they need to freshen their skills. We're all really had to pivot during COVID, but I think utilization of telehealth can be really effective, especially during staffing crunches, to facilitate more timely intervention or reduce utilization or keep someone at home, being able to intervene. Maybe don't necessarily have someone at 3 o'clock in the morning that can run out, but if I can use telehealth and see what's happening in the home, that can be really effective in improving outcomes as well. I think, as we're all shifting towards this value-based model, we're really should be focusing on outcomes and really understanding where the quality is leading to improve the quality of care and kind of better patient experiences. But really, I think creating that culture of safety is really essential for job satisfaction as well.
I would agree with that. And I think one other point I'd like to bring up is, as we've all gone through this and we've really been challenged with educating our staff in different ways. And like you said, through videos, teleconferences, whatever it may be. I found that really embracing our physicians as well and our medical directors in hospice and home health and giving them the knowledge base as far as the QAPI and the operational initiatives, clinical initiatives, and quality initiatives, and really get them on board with the team as a voice to help us communicate with our team and with our patients and families as well. So really embracing the physician as well has been something that we have found has really helped that overall.
Well, Nicole, you touched on embracing technology in the first question, and I love that point because I think that, the misconception with technology can be that it almost takes you away from the care side when really it should augment the human side of care and allow clinicians to have more time to spend on critical care. And so that kind of leads into our next question. Have you well, first off, again, audience, any questions, comments that you have? We see a couple coming in. Please make sure you ask those. Would love to hear any questions, insights that you have to provide and have it be a part of the wonderful panel that we have here. So the third question, can you think of any programs that you've implemented, measures that you've implemented that have helped save money while improving the clinician experience and patient experience?
So I worked in kind of a rural community in Augusta, Georgia, and we had patients who didn't fit into the area that pharmacies would deliver. They'd have to go to a local tiny pharmacy. And we had a lot of people like this because our service area was so large. And some of the things that we had to sort of, pivot and implement for these folks, because we didn't get those patients all that often, was just truly looking at the entire picture for that patient and making sure that our nurses did the simple telehealth thing of calling. I mean, we were calling all the time. Yes, somebody might have been on, 2 or 3 time a week visits, but without fail, we had time built into our nurses' schedules on Thursdays and Fridays. They did not see their full complement of patients, and they were in there calling the people who didn't get Thursday, Friday visits. Now we can swap that out for a telehealth visit. We were doing these things before they were, they were real, and we were just doing them without a screen. But because those people live in those rural communities, they live so far out, they don't have a car, they don't have transportation, those check-ins or those telehealth visits, one, are so timely for them. They call, they have an issue. We had a nurse in the office who could jump on a telehealth call, even in the middle of the day, to support them, versus a nurse having to add another visit to her day at the end, and then drive all the way out, an hour and a half sometimes, and be paid the wages, and the family had to wait that hour and a half. So that telehealth piece, or like what we do here, being able to have CareXM as like a bank of nurses as a resource for triage, we didn't have that piece of it, but we had a triage nurse in office, which was usually just the director, but that saved us a lot of time, a lot of money, a lot of satisfaction, because we weren't sending a nurse out, running all over the place across 7 counties in some cases to get to a patient. And I think we used to say before the pandemic, just globally across the workforce, not just healthcare, but, oh, it doesn't work to work remotely. It doesn't help to have this telemedicine. Like it's not going to. We've seen it's going to. It did. It does. Is it perfect? No. But just because we're living in a post-pandemic world doesn't mean we didn't learn these lessons and can't apply them moving forward. And so, having that, they're still using that telemedicine like visit model back where I used to work. They're still doing it to this day. The nurse in office, whoever it is that day, is the person, and they have set up a situation where they can do a telemedicine visit with their nurse and get that information relayed to the doctor. And in some cases, even the nurse practitioners can do the same, because the nurse practitioners that work alongside those medical directors, they're working in a practice somewhere too. So they don't have time necessarily for a home visit, but they've got time for those telemed visits. And it changed a lot of the landscape of our after hours and on-call services too.
I agree. Don't you just love the telemedicine visits, especially for what it can do, preparing the patient and the nurse while the nurse is on the way, you know?
Absolutely.
You can see into the home, you can kind of see the settings, you can see what the patient looks like. Before it was just words telling us, but now we can visualize them. We can describe a patient to the physician when we're calling the physician, maybe while we're on the way to them, make that visit. It really just economizes nursing hours. And I think it really contributes to better outcome scores, quality outcome scores for us, because it's a real touch. I consider a televisit a touch almost, that really gives the patient a feeling of security and value in what we're doing for them.
There's not that gap in between I made the phone call and the nurse comes. And during that gap, they feel so alone, like, what am I supposed to do? And I don't take a lot of triage calls anymore, being the clinical educator and teaching more. But when I do, and I have that opportunity to, somebody calls and says, I need the nurse. I am the nurse. Well, no, I want the nurse here. I got you. We're going to take care of that. But in the meantime, I'm not sure exactly where she is at this moment, and she might be in a visit. So there could be a little period of time where she's going to be driving, and it would be unfortunate for your mom or dad to be in pain during that time. I'd love to help you. And I can't see anything. It's just on the phone, but I'd love to help them in that short period of time. Yes, sometimes that leads to a visit not being even necessary.
Right.
But for the visits that are necessary, that quality and that feeling of being totally enclosed by the hospice experience, and not having those holes for them to fall through. Oh, we waited an hour for the nurse, and in that hour, dad was confused and got up and fell. We've got symptoms managed, but we're still making a visit. And that, I think, has been the most, the most rewarding part of being a telephone triage nurse, or being any part of that person that picks up the phone. Even when I was a hospice nurse and was on call, knowing that I could help them while I'm getting ready and getting my scrubs back on and running across town, you're working the whole time till you get to them.
I think the best type, oh, sorry, Jeanette, go ahead.
I was just going to throw one last thing in there, that I think it really enhances our ability to determine if we need other disciplines to go and visit as well. Maybe they need a social worker or chaplain. And if you're doing a televisit or a phone visit, you might hear something in the background, or you might see something, as you're doing the televisit, that kind of clicks in your mind and goes, oh, I think the father or the brother or whoever it is, I need to get a social worker out there or a chaplain out there too. That sometimes just didn't get conveyed as well as we find it does nowadays. So bringing the whole team into those calls is really part of it as well.
I think the best type of customer service is really able to anticipate what patients and families need, and it can help create a more predictive model of care. So anywhere that you can collect data to see where your opportunities are by tracking the call types that are coming in, it really allows for you to be more intentional regarding process improvement or standardizing and streamlining. That analyzation and optimization of workflows can really increase, or I'd help identify your inefficiencies and kind of streamline process. And, to Jeanette's point, look and see what other disciplines can we pull in, and who is the best person to go next.
And really that creates efficiencies and helps us be more effective in the dollars which we're spending to care for a patient, but also gives us better outcomes.
I think in the hospital setting, we're so used to, if you've worked in a hospital in the last 20 years, you have had that old statement of, when you're leaving a room, is there anything else I can do for you? I have the time. Like, I think all of us have heard that statement. I think in community-based care, it's really easy to forget that, because you're like, oh, I'm going to see him again Tuesday. Oh, the CNA is going to be there tomorrow. But truly, that was one of the things that I pushed all of my staff, not just my nurses, my social workers, even the chaplain. Is there anything else I can do for you before I go, or before we get off this call, or whatever? I have the time. So that, social worker, if they're making a visit, they can take a pack of, undergarments, or if the CNA is going, they can take, a certain item, rather than sending somebody out who wasn't going already. Because when I started, I found we had a lot of people making supply runs, just straight up supply runs for no other reason. And I thought, somebody was there yesterday. No, it wasn't a nurse or a CNA, but somebody was there yesterday. And so the ownership of the patient and the overlap of all of our roles, I've always said as a nurse, just thinking of it from a hospital perspective, my job is everything from RN to unit secretary to med tech to CNA to janitor. I overlap all of those roles. I have to be able to perform all of those roles. And the same thing is true in community-based care. I have to be able to think like a nurse, even if I'm working as a social worker. This person needs this item, or what could they possibly need? And when we look at our visits and the care that we provide and the collaboration between all of our disciplines, that really is the way we should be working, is covering down that overlap for each other, which then hopefully leads us to less of these extra visits, or those emergency tuck-in visits at 4 o'clock on a Friday because we forgot to do something. If we're all owning that piece and that care for the patient.
And I think it's a challenge for leadership is really determining what your team needs to accept that responsibility.
Yeah.
Agreed. Now we have a comment, a couple of them coming in, questions. One is brings up the point that your customer is also the patient in a year or two. We need to be around as a business to serve them, which I think we all agree. I think often we look at, well, we need to focus on patient care and then, caring for our clinicians, and we forget about, well, we also have to care about our P&L. We have to care about, because the more fiscally responsible we are, the more we can invest, in technologies and in solutions to help out with patient and clinician care. So I think you guys all would agree on that front. I thought that was a good comment, though. So I'll move on to the next question. Any insights on how to improve timeliness of care? And we all live in an Amazon world and want our packages next day. We dang sure want our loved ones cared for immediately. Any insights that you can provide on improving timeliness?
I think it's about the relationship building and the right nurse for the right family. If you don't have the right clinician in that home, you're not going to have that open line of communication where people feel comfortable to express their needs and be honest about their abilities and expectations. It can be very hard for the wrong nurse and the wrong family together to really create that plan of care together in a way that actually meets their needs, because the nurse is thinking, I have 8 visits to do every day. I've got 20 patients on my roster. I've got to fit this in there. When we stop looking at our schedules and how much we have to do, and we make it about just what they need and only that for that time frame, we can figure out the visits later. We can figure out who's going to do what. That's fine. But I think as nurses, I know I did in my early days in hospice, I came in and I approached everything with okay, where am I going to put them? Where am I going to fit them in? How am I going to do this? And it just led to me not being the best nurse I could be in their house and for them. I was friendly and I was kind and I showed up, but it didn't allow me to be timely with my care, because I was just sticking things in where they fit instead of saying, this patient doesn't get up till noon. So I know that forevermore, my visits are going to happen afternoon, and I'm going to carve out space for them instead of going on the fly and just trying to fit people where they fit. Taking a really holistic approach to looking at the family and their needs, and only looking at them as I'm putting them on my schedule and not worrying about where else they're going to fit. And then also looking at it from a logistical perspective, we had GPS tracking with our devices, and we all started going in the morning and putting our schedules into, I think it's called Road Warrior, where it plots out your path to make it the most travel friendly, whatever you want to say. Mm-hmm. And making sure that we adjusted where we could and where it was possible, but those people that really had that specific timely need, those people were seen on the schedule we provided. One of the biggest dissatisfiers, and the thing that led people to leaving, I think more often than not, was nobody called to schedule my visit. Nobody called to confirm my visit. I don't know when they're coming. I've been that was due for a dressing change last night, but they're going to come today, but today is now turning into this evening. Those are the things that lead us to less humanity in our care. And worrying about where people fit on a calendar is like the last thing we should be doing.
And I think that bounces back to specific focus training for our new staff that comes in. And even if it's an experienced hospice nurse, they may have learned in a different setting, or an experienced home health nurse, they learned in a different setting and they didn't learn those skills like you're talking about, Christine. So really taking a good look at our training programs, our orientation programs. How do we empower our staff to learn those keys to delivering good care, timely care, and still look at their patient load so that we make it available to them to have that time?
I think anywhere that we can have predictive analytics, so implementing models that we can anticipate needs and identify, potential bottlenecks, and really kind of optimize how we're utilizing our resources. For example, tracking turnaround time from referral to admission and setting a benchmark for that data and conversion rate, or really digging in and looking at patients that weren't ready or didn't come on service and having a follow-up mechanism for that. Looking at types of after-hour calls that we're getting and what resulted in a visit, what was the reason for the visit, or if you have a significant volume of refill calls at 3 o'clock in the morning, it's an opportunity to kind of look at your model of care and implement action plans in order to mitigate those after-hour needs. When was the last visit? Did they do a full med rec? Kind of working backwards to get to the real opportunities, I think is really important to improve timeliness.
I think that goes back to really teaching your case managers and your team about the things you just spoke of, Nicole, how to strategically look at their schedule on a daily basis, and then give them that education, and mentors, preceptors as well.
That's great. Well, and to that point, I mean, so we've talked a little bit about kind of, some ways to improve overall. What are some strategies though to help RNs operate at the top of their license, to help remove some of those other medial tasks, to just spend more time on critical care? Have you adopted any or have seen anything as far as outcomes work for your teams?
I think to your point, delegation and task redistribution. So identifying tasks that really are safely and appropriately delegated to other disciplines or admin staff that can be done in the office, to allow for the RNs to really focus on the complex and specialized care and spending more time in the home than that documentation burden that I talked about before. What's essential, what's a nice to have, and really kind of looking all the way through our processes and saying, okay, what absolutely has to be done by the nurse, and where can these other pieces land within how we're set up operationally?
And it's so important at your team meeting to get to those core things that Nicole mentioned. And that's a big challenge in itself, is learning to run or learning to set up a team meeting so that you get the outcomes that we've talked about for the last 30 or 40 minutes. How can we help an RN do those RN tasks? When is a social worker needed? Because typically we as RNs, as Christine said earlier, we like to take it all in, and they're my patient, but looking at it's our patient as a team. So how do we use that whole team? How do we communicate with each other as team members from team meeting to team meeting, and really bringing that holistic care to the table, instead of sometimes team meetings are just a report time instead of a planning time. And I think at that time, if you really focus on each one of the needs of the patient and the disciplines that can address those needs, and then make sure you come back together between those team meetings, then we get some really good, effective practice within the different professional roles, and we get really good outcomes for our patients and families.
Exactly, to your point, like investing in that workforce development, going back is, not many of us are growing staff in our backyards, right? So staff development and retention is so crucial. Creating fellowship programs or residency programs, transition into practice programs, so that you're investing and cultivating your career ladder. Developing training programs and career advancement opportunities, incentivizing staff for certifications, and kind of mitigating staff challenges, while we're enhancing the quality of the care that we're providing.
I agree, and really knowing what kind of specialties our current staff have.
Right.
I know in my past, I had a couple of wound care nurses as RNs, the hospice RN case managers. I didn't realize they were certified wound care nurses. When I found it out, I was like, oh my gosh, why didn't I know this before? So really understanding their specialties when they come to us, and then understanding and hearing what specialties they'd like to develop while they're with us.
I think also bringing the patient or family caregiver, whomever is responsible for the day-to-day decision-making for a patient, bringing them into the process and the understanding of what happens in visits. So often we go out and do these visits, and they know we're coming and they know we're providing nursing care. But I mean, the number of times where my 30, 45-minute expected visit turned into an hour and a half because there was a heavy load on their heart. They needed to share something. And maybe they've only seen the social worker twice and they weren't quite as comfortable with them, but they were with me. So, for them, trying to explain during our starts of care, this is what happens in a visit, and I'm here for you. And, these are the people that are involved in your care, writing it down for them, making sure that they know where it is. And I know we, like a lot of us, do those admission folders and we keep them in a central place and we bring it out every visit, but really helping the patients and their families to understand, what is a nursing visit about? What is a social work visit about? No, I'm never going to turn someone away who needs, an ear. But, to Jeanette's point earlier, those are the times where you say, you know what, I've got this person, I've got this social worker, they're amazing, because what I found happening as a new hospice nurse many years ago was my visits got longer and longer and longer because my heart got bigger and bigger and bigger, and I couldn't say no because they needed someone. And I wasn't leveraging my coworkers the way I could. And I was one of those nurses. I was like, that's my patient, that's my family, I love them. But when, as nurses, when we let go of that and really realize, like Jeanette said, they're our patient, all of ours, we all have relationships. And again, we all have things that we do that overlap. Making sure the families understand what each one of our individual roles is allows the nurse to go in and actually provide nursing care, yes, still a listening ear, but with a focus on actual nursing care as well.
I appreciate. We're getting quite a few more questions here, so I'm going to start hitting on those if you guys are okay with that, and then maybe we can share, if you wish, just some outcomes that you guys have deployed at the end that you've seen work. So real quick, how are you thinking about adjusting again for telehealth and RPM if coverage for these tech strategies are no longer covered under payer contracts?
I think it's a complement, not in replace of an in-person. I think for our providers, it will continue, or our physicians, and will continue to be allowed, I think, through 2024, if I'm not mistaken. But really utilizing it as a complement and not in place of, leveraging, to Christine's point, kind of utilizing it as we're sending somebody out. And I think the reimbursement model for home health and hospice is very different. So for hospice, using it as a complementary therapy, we're getting paid a per diem rate per day. And so for us, it's not as tricky as trying to figure it out for home health, to be fair.
Yes.
That's a great point. And me, I mean, it seems like it could be more of a cost savings measure to leverage the technology to reduce visits, right? And that was, Christine, your point, a little bit earlier.
With what we do at CareXM with our triage and things like that, although no, it's not eyes on telehealth, I will tell you the number of times that I've taken a call and asked the right questions and can see, minus hair and eye color, can see a picture of this person in my mind. in putting the right people, whether you use a service like CareXM or you use your own staff, putting the right people after hours in those positions that have those assessment skills. I tell our new nurses all the time when they're in training, when people call and need something, you're doing a full physical assessment without your eyeballs. You know, you have to be able to ask the right questions and put this picture together so that you can provide the support. If we have the wrong people in those positions, it's just going to result in a visit anyways. But the right people in that space that ask those questions, or utilizing a, like CareXM, like a triage service, I think can sort of help out that space where, maybe a telehealth visit, or, in places where video visits just aren't possible, due to cell service or internet coverage, a phone call still can be a very valuable resource, whether it's from your own on-call staff or from a triage service, if the right people are answering.
I would agree, Nicole. I love the way you put it, to think about it as a complementary service. And I think the outcomes that we'll see from that are definitely better patient satisfaction scores, in timeliness, in after hours response to that question. And just, it's all about how we make the patient and family feel. If we make them feel comfortable, if we make them feel secure, if they make them feel that they can count on us, we're going to have good outcomes on those surveys.
Great point. Love that. Okay, another question. My home maintenance service lets me know when the service folks are coming out and uses GPS technology to allow me to track their arrival. Why can't we use those? That was a question. I think we all agree. I know on our end, we have geo tracking in place for our RNs where we can see where they're going and who they're visiting, and working on security measures. But I think we're all in agreement that, yeah, well, let's make that happen. I would love for it to be a DoorDash type, look of see the car,
Yeah.
make way to me, or especially my loved one.
If we
This is
can
that
get
embracing technology piece.
Yep.
Exactly.
Technology to talk. Wouldn't it be wonderful to have it like
I see a business for all of us. I see a
Yes.
Yeah.
Well, we got it on the roadmap, so we'll get her done. Then another question here is: anything different being done to recruit and retain the hospice aide / ancillary support staff?
We've seen in a few of the Providence hospices, we've brought on CNAs and then helped pay for them to obtain their licensure as part of their onboarding. And so that can be a piece of support, not necessarily an incentive, but helping them continue to grow within their specialty. I think is definitely a value add. So we're not just talking about, nursing and social work certification, but to your point, looking at all of the supportive staff within that interdisciplinary, transdisciplinary team. That was one of the recruitment ideas that I thought was really outstanding.
I think that's where even we used to call it the clinical ladder programs that you have as a company internally, even for the home health aides, a home health aide 1 or 2 or 3 that has different criteria within your company itself, and then measuring maybe how that aide performs with, patient and family outcomes, so that they can see themselves moving up within a company as well. And then also really looking at if it's a possibility to help them, if they want to go ahead and go into nursing, what can we do to help them go into their career of their choice within healthcare. So I think we've got to be real creative with all of our disciplines on retention.
Okay. Any more questions that come in? We have a few more. We'll try and get to those as well, but keep them coming because we'll answer them today, or we'll answer them after the panel is over as well. So any outcomes that you can share with the audience that you've seen, measurable or, qualitative, quantitative, that you've seen to help provide, that helped you get ahead of some of the challenges and the associated strategy that led to the result?
Well, I can share a little bit about our partnership with CareXM. When we were looking at our overall structure of our after-hours services for our hospice, and it was at an enterprise level. So we were looking at caring for about 5,000 patients. So how do we do an excellent job after hours and weekends? Because that's the majority of the time that we serve our patients and families. It's not 8 to 5 when the case manager is there, it's after hours. And what we found is it was a year-long initiative as we looked at why our patients and families called us after hours, when our patients and families called us after hours, and did we meet the needs of whatever that call was related to. So it was quite a big QAPI project. But when we brought all of this together, we found out that we could have different models. We all want to do the same model across the company because it makes it easier to measure. But we found that we could still use our internal triage staff. We could still use our CareXM triage staff. And we could still use our smaller acquisitions that we made with their on-site call and triage staff. But it was just how we blended all that and how we put it all together and what providers we used to help us in that. So it was a huge initiative, and we were able to look at why, who, what, where, when, and how everything happened, those core questions. And we were able to economize our staff. We were able to use less staff because we could do exactly like what was mentioned earlier is the geo tracking. We could see where most of the needs were. We could see the hours within the day that we needed more staff and when we needed less staff, because typically we as hospices and home health just staff the same, and don't look at it in a proactive way when we grow. So we were able to do that, and we were able to grow, but we didn't have to add that much to our triage staff. And we saw our calls from our patients and families trend downward numbers after hours because we worked hard on taking care of those patient needs as a team during the day. So it was a quite ambitious initiative, but we got the outcomes we were really looking for.
Piggyback on that, I think, having access to data that CareXM allows us to see really allows for us to pinpoint exactly where we should be paying attention. The heat map that we get for call volume allows us to fluctuate staffing. The technology that comes with CareXM allows for us to have staff that work locally within an office, but then can also be virtual. We're able to have that blended model, especially during COVID when we have, parents who are caring for children who are also home. It allowed us to really be flexible, but it's allowed for us to benchmark internally. I mean, Providence is a fairly large organization, and we're able to, standardize the way that we code our calls so that we can see and leverage best practice internally against each other. It's improved our timeliness of care. It's improved our approach to getting help with symptoms. One of the biggest projects that we implemented was the opportunity to really focus on not only help with symptoms, but the education and communication pieces around what to expect. We've created a what to expect booklet by symptom, gone over, things that are visibly seen, the perception that patients and families can have around certain types of symptoms, and that allows for a collaborative location to write certain interventions down. Call us if you see this. If this hasn't happened in 3 days, please call us. And it kind of creates this symptom management notebook that's individualized for each patient and family. But we wouldn't have had the transparency to that data without having leveraged the technology that's available to us through the CareXM platform. So
I agree with both of them. We did not have the benefit of CareXM. We were using a non-clinical answering service, and in rural communities where there's no cell service, if you're on a visit and your phone doesn't ring, you don't know someone's calling. So there were some days I would come out to the highway after an hour and a half visit and find 4 voicemails, and I'm the only person on call. And it's heartbreaking because what we do is so important, and being there for them is so important. And we make these amazing promises of there's a nurse on call 24/7, someone will be there. And then I'm out in the middle of nowhere and I have no cell reception and I can't do a thing about it. So we pivoted, and we actually got rid of our answering service because we didn't really, we were finding it wasn't helpful. And all of our calls were going through our director or our administrator first. And we were providing the triage, and then we would call a nurse. It's great for our bottom line, terrible for our life and job satisfaction. And we, had to sort of internally look at, like Nicole said, like, when are the calls coming in? What are they coming in about? In some cases, who's the case manager that's getting the most calls, and deal with each one of those issues individually. And we also did a lot with education piece. I actually lowered our, number of visits per day, whatever we want to, say. We just lowered their patient load a little bit and really put a huge focus on education. No, we're not as productive as, visit number wise as we could be, but our satisfaction scores dramatically improved, and the number of phone calls we got dramatically reduced. And what we found realistically is that our nurses did not have time to provide the care, be the support person in that moment, and educate. And so we had visits that we had built in that were more focused on education. We had a binder that was tailored to the patient, and we did a lot more teaching, because when they understand what's happening, and they understand that that caregiver is empowered to care. We take people on who have caregivers, and then we don't teach them, because we're so busy. We're doing all the care. Teaching that caregiver and having them own that piece of care while we're not there, but making sure that they feel really confident in what they've been taught and how to execute, really led to a significant decrease in our after hours calls, which led to a huge increase in my job satisfaction, because I didn't have to triage calls all night long and then call someone to send them out. Yes, the benefit for our nurses was they could be extremely present at the bedside of someone who had just passed away without their phone ringing, and the family is being like, do you need to get that? We understand. No matter how much they understand, it's still something they remember, that the phone was ringing off the hook when the nurse was dealing with a death visit. Or it allows them to sleep so that they can be fresh for that next visit. And that for them led to a lot greater retention. It led me to, need to have like Starbucks on a tray next to me all day, every day. So leveraging, a clinical triage, or in our case, we're clinical and non-clinical, would have been an absolute godsend for us. And we just didn't have, because this was quite a few years ago, we just didn't have that at our disposal. It was non-clinical, and that's all we could, find at the time.
I think COVID made us move more quickly than we ever have to think of new ways to care for patients and families. And I want to encourage us to really continue to embrace innovation. And, staying ahead really requires a commitment to, embracing and adopting new technology and to enhance care delivery and improve outcomes and subsequently reduce costs. So I know that things have calmed down a little bit, but I really would encourage us to continue with that innovative mindset, to think differently about how we can continue to care for patients and families as the patient population that we will care for continues to grow.
Yeah.
I don't have anything. I think we need to end right there. I mean, we can tie them back to the RPM telehealth side, because there's benefits there with patient engagement, education, how that can relate to self-care models and improve value-based care with the outcomes. That might have to be another thought panel another time. Great job. Thank you, all three of you, for your time today and thoughts and expertise. Thank you to the audience for joining today, especially and adding some of your thoughts, comments, and questions. Please feel free to reach out as well for additional questions. And thanks to Home Healthcare News for hosting today. Everyone, take care. Thank you.
Thank you.